The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello, everyone. Thank you for joining us today to talk about the era of immuno-oncology of triple-negative breast cancer and how it relates to surgeons. I am joined, my name is George Pletus. I come from Sloan Kettering from New York, and I am joined today by Dr. Heather MacArthur from Cedars-Sinai. I am a surgeon who has an interest in translational research in the biology of TILs and breast cancer, and Dr. MacArthur is a medical oncologist who has done extensive clinical and translational work on immunotherapy for breast cancers. And so this will sort of be composed of two sections. One will be an introduction into the immune response against breast cancer and sort of the rationale for harnessing immunotherapy in triple-negative breast cancers. That'll be led by myself. And then to follow, Dr. MacArthur will talk about some of the clinical trial data and sort of strategies to try to improve the immunogenicity of breast cancer so that we can get better efficacy across the board. And then following this, there'll be a sort of practical question and answer session towards the end. So for my section, I'd like to talk about the immune response against breast cancer. And so breast cancer has classically not been considered a immunogenic cancer, but I'm going to show you today how that's not necessarily true. And the first thing to understand is that the tumor microenvironment or the mass of a tumor is not just tumor cells. There are a number of complex normal host components that take up residence within this sort of very complex environmental niche. And they're all critically important and to some extent led by the malignant epithelial component of the tumor. And one part of this environment is the immune environment. And it's always present, but in varying degrees. And it's composed of the innate immune system, which includes things like NK cells and certain myeloid-derived cells, as well as antigen-presenting cells. There is the adaptive immune response, which are B cells and T cells. And then again, a more sort of broad myeloid compartment, which includes myeloid-derived suppressor cells, macrophages, and monocytes from the bone marrow. Now, the one thing that I want to show you is that this immune system we always think of in isolation, the immune response to any cancer. But in reality, if you look through all sorts of data, you can find that it pops up over and over again. And for instance, triple-negative breast cancer has been classified based on gene expression from the original Lehman studies, and then further classified here by this Baylor cohort. And it's very clear that gene expression will break up triple-negative breast cancer in very distinct biologic subsets. And even though this is gene expression, clearly the immune system, the cells that occupy within the tumor, play a huge role. And the two major subsets of the gene expression derived subsets are the basal immune activated and the basal immune suppressed. And the big difference between these groups are the presence of immune-related genes that are being expressed, such as cytokines and chemokines and various activation molecules found on immune cells. And the other theme here is that the presence of an immune response is prognostic. And so in this group, for instance, the basal immune activated, which is defined by the presence of these immune genes, has a better prognosis, or the best prognosis potentially. Whereas the basal immune suppressed, which lacks these genes, has a worse prognosis. And so this is a recurring theme. And the other thing to note is that the various subsets of triple-negative breast cancer can also be used to define very specific treatments for them. And so the basal immune activated is often thought of potentially being more responsive to immunotherapy because there's a pre-existing immune response. And then there are strategies for the basal immune suppressed to increase the immunogenicity by providing combination therapy. other than transcriptomics, we also classify triple negative breast cancers based on genomics. And this is a classic sort of description of the genomic alterations that are found in triple negative breast cancer. And as you classically will see, a predominance of P53 mutations. But what does that have to do with the immune system? Well, one of the things that comes up when you look at genomic abnormalities of triple negative breast cancer is that you see very often a higher frequency of mutations in triple negative breast cancer versus other types of breast cancer. And this is thought to be a potential biomarker of response to immunotherapy, and also potentially a more immunogenic tumor overall. These mutations will often lead to novel antigens, so proteins that are altered enough that they could be recognized by the immune system and potentially be the basis for an immune response. And so equally as complex as the transcriptomics and the genomics are, it's no surprise that the immune response is also very complex. And while immunologists tend to think of immune subsets as very polarized, Th1, Th2 for CD4 T cell subsets, and most of this comes from data that are that mimic conditions that are highly polarizing, such as infections. The tumor, however, is not quite so simple. And in this study, where we looked at single-cell RNA sequencing of tumor-infiltrating lymphocytes from breast cancers, as well as from normal breast tissue and lymph node and blood, and using a standard t-SNE analysis, you could see that when you look at these plots, and so each cluster or each color is a unique population of immune cells, you can see how much more heterogeneous the tumor is as compared to normal, and how simple the blood looks in comparison to tissue-based immune subsets. And these in the tumor, at least, it's highly complex, where you think of the very simplistic nature of T cell differentiation in sort of classical context. Here we found 38 different unique T cell clusters, 15 of which were CD8 and 21 of which were CD4. So what this tells us is that the simplistic understanding of the immune response in other settings may not necessarily apply to tumors. It also sets up a daunting prospect that we would be able to find blood biomarkers that could sort of correspond to what's going on in the tumor. So very complex. Now, it would be great if we could use plots like this for every single patient, but that's not quite yet prime time. And for the most part, this is what a clinical manifestation of immune response looks like to a surgeon on a day-to-day basis. It's basically the presence of an immune infiltrate on an H&E slide. This is evident by looking at the little blue cells that are infiltrating in the stroma of tumors. And here on the left, you could see a tumor where there is a dense lymphocytic infiltrate. And on the right, you can see a tumor that there is barely any lymphocytic infiltrate. And we sometimes call tumors on the right cold and tumors on the left hot. But nonetheless, it's not always so dichotomous. And in reality, there's quite a spread between tumor to tumor. There is a range, a continuous range of lymphocytic infiltrate when you look at a large sampling of tumors across different patients. And they range from almost nothing to a potential lymphocyte predominant breast cancer, where greater than 50% of the tumor stroma is occupied by lymphocytes. And so when we think about TILs, or tumor infiltrating lymphocytes, in clinical studies, we often categorize them in two ways. One is a continuous variable, because you could see the continuous nature of this factor, or sometimes we pick up a cutoff and make it a dichotomous value, like 30% or 50%. And so TILs can vary significantly by frequency, but they can also vary by location. And so you can find tumors in a peritumoral region, sort of outside of the tumor mass. You can find them within the stroma, which is sort of the matrix between the epithelial nests of tumor, or you can find them within the tumor nests themselves, intratumoral lymphocytes. Now, triple negative breast cancers tend to have more frequently the presence of stromal TILs. In this analysis of TILs from a large adjuvant chemotherapy trial, you can see that the median percent of stromal TILs in triple negative breast cancers is about 20%, whereas the intratumoral TILs is only about 5%. And also, when you look at prognostic outcomes of TILs, it becomes clear that the stromal TILs is more of a robust indicator of outcome than intratumoral TILs. And so for the most part, we analyze tumor-infiltrating lymphocytes in the stroma of triple-negative breast cancers. And so what's the hypothesis is that this immune response, these little blue cells that we see on H&E stains are relevant, right? And why would be the case? Why would this immune response be clinically relevant? Well, you have to go back to the cancer immunity cycle, and this is another sort of classic diagram. I'll take a minute just to go through it because I think it's important. And so the immune response against breast cancer happens, we think, in stages. And the first stage is that a tumor becomes somehow immunogenic. And that is not a small feat because, as you can imagine, a tumor is mostly self. And there are very powerful mechanisms in place for the immune system not to recognize self. It's not like a virus or a bacteria, which is clearly very different from our normal tissue antigens. So something happens to a tumor to allow it to be antigenic, like the presence of these mutations that can lead to novel antigens. These antigens then are picked up and picked up by antigen-presenting cells. These antigen-presenting cells travel to regional lymph nodes, and they encounter adaptive immune cells, such as T cells and B cells. There, they activate and prime those T cells, which gives them the ability to then home through tissues, through the blood, transverse lymphatic endothelial cells or endothelial cells into the tumor, recognize the antigen, which should be, hopefully, presented by MHC molecules on tumor cells, and then kill the tumor cell that's presenting that antigen. And so this process, if it happens, you can imagine might be clinically relevant because you have a constant mechanism by which tumor cells can be eliminated. So what is the evidence that this is important in triple-negative breast cancer? Well, there's a couple of lines that I wanted to go through. One is the natural history of disease. Two is the response to therapy, chemotherapy, and then the response to immunotherapy. So we don't have that much natural history data for triple-negative breast cancer. In other words, not to treat with any systemic therapy. But in this small study, which is a multinational effort to try to get samples in of patients with triple-negative breast cancer who did not receive any adjuvant or neoadjuvant therapy, and if you look at the outcome of these patients based on the TILs that were analyzed in their biopsy specimens, you can see that there's a continuous effect with the increased presence of stromal TILs to outcome. And so the more stromal TILs there are, the better the outcome. This is often referred to or presented as for every 10% increase of stromal TILs, there's a proportional improvement in outcome. And if you look at the hazard ratio here for this analysis, it is modest, but pretty clear across the different origin of these samples that you have a protective effect in outcome of invasive disease-free survival by having more TILs. And this is the projected sort of survival analysis in a dichotomous fashion where you choose a TILs cutoff as 30%, more or less than 30% of stromal TILs. And you can see the patients who had greater than 30% had a better outcome than those that had less than 30%. I will also note here that most of the patient samples here did fall into the less than 30% range, and only about a third of patients had greater than 30%. And this actually follows suit when you look at immunotherapy as well. The majority of patients will not have benefit, whereas the minority may have. And this lends itself to believe that maybe the pre-existing immune response would be important to predict outcome. And we'll talk more about that in a second. So this is natural history, very limited data. We have a lot more data, however, in the setting of systemic therapy. And so this is an analysis of 2 adjuvant chemotherapy trials with long follow-up over 10 years, 500 patients. And again, they saw for every 10% increment in TILs, there was a 14% reduction in the risk of recurrence or death and an 18% reduction in the risk of distant recurrence. And this prognostic effect was maintained in multivariable analysis. And again, you can see the continuous nature of the improvement in outcome when you go through the varying sort of degree to which the tumors are infiltrated. So this could be considered maybe a small analysis, but even when you look at a larger meta-analysis with over 2,000 patients and 9 different trials, this holds, right? And so this hazard ratio of the continuous effect of stromal TILs in this combined analysis, you can see is 0.86, which is better than what we saw with the natural history studies. And so it lends itself to believe that adjuvant chemotherapy does somehow interact with the presence of an immune response. And this linear relationship between the increase in TILs and disease-free survival is robust enough that you could even start to make individual patient prognostic sort of determinations. And so these data were sort of coalesced into almost like a nomogram, and you can go on this website, tillsandbreastcancer.org. You can plug in some basic demographics about a single individual patient. And the algorithm that is described here in this paper by Shireen Loy will develop a curve, a survival curve that is varied depending on the degree of stromal TILs, and you can figure out what the individual patient's stromal TILs frequency were and figure out individual patient prognosis. Now, this is all sort of very new and experimental. It doesn't really factor into our day-to-day management of patients, but nonetheless provides a pretty powerful tool for future research. Now, what about immunotherapy? Oh, sorry, neoadjuvant chemotherapy. We talked about adjuvant. What about neoadjuvant? Well, not surprising, since there is this relationship in the adjuvant setting, there's a relationship in the neoadjuvant setting. And one of the factors that we look at frequently in these types of trials is complete pathologic response. And in this analysis of over 900 patients from the German breast cancer group, we can see that if there are tumors that are highly infiltrated by lymphocytes, there is a significantly higher likelihood of having a complete pathologic response. And this correlates to improvement in outcome. And so TILs actually happen to be a very powerful and one of the few markers we have to predict the likelihood of having a complete pathologic response, which we know can be a surrogate for outcome for triple-negative breast cancer patients. And what's interesting is that when you look at the residual tumors in patients who did not have a complete pathologic response, the presence of TILs continues to be prognostic. And so if you have residual disease and there are lymphocytes present within the tumor, you have a much better outcome than if you don't have lymphocytes. And what's also interesting is that where those lymphocytes are change when you give chemotherapy. And so there's a higher likelihood of now having intratumoral TILs rather than just stromal TILs after chemotherapy, which suggests that chemotherapy might be doing something to the immune response against breast cancer. And this is one of the rationales for combining chemotherapy with immunotherapy, in that the chemotherapy can potentially make tumors more immunogenic. So why would it be the case that the immune response is predictive of chemotherapy response? Well, one of the interesting preclinical studies that have been published by Karn et al. From Yale is that potentially the immune response is editing tumors. And so what they did was they took genomic data from a number of triple-negative breast cancers, and they had gene expression data as well. And they correlated the genomic heterogeneity of tumors with this gene expression data, specifically looking at signatures of an immune response. They called this the T-cell metagene expression, and they had various measures of genomic complexity, this sort of mutant allele score that's representative clonal heterogeneity, and then just simply somatic copy number alterations. And what you could see is that there's this relationship. As the tumors are more immunogenic, or they're more inflammatory, or have they more T-cell genes, they are less complex. And that suggests that the immune system is editing these tumors and potentially even editing out tumors or cells or clones of cells that are resistant to chemotherapy. And so these similar tumors may have less chemo-resistant clones, and that's why we're seeing better responses to either neoadjuvant or adjuvant chemotherapy. So there's plenty of data to suggest that the immune response is playing a role in the outcome of triple-negative breast cancers. Well, what about immunotherapy? Well, immunotherapy involves sort of either taking a pre-existing immune response and making it better, or maybe inciting an immune response where there isn't one. And the main route that we're investigating clinically, or the data that's coming out from clinical trials now, is targeting in this PD-1, PD-L1 pathway. Now, it's important to understand that the immune response against breast cancer isn't necessarily something that's tumor intrinsic. We are all born with intact immune systems. And so why is it that we're getting that our immune response in tumors doesn't always eradicate the cancer? Well, it's because that there are tolerogenic mechanisms. So as the immune system evolved to fight against foreign pathogens, most of which are virus and bacteria, they became better able to discriminate foreign from self. And this prevents autoimmunity, which could be catastrophic. Now, since tumors are mostly self, many of these mechanisms that are in place to prevent autoimmunity are sort of co-opted by tumors to prevent an immune response. One of these mechanisms is this idea of checkpoint blockades. And these are a set of molecules highlighted by PD-1 and CTLA-4, which are upregulated on T cells right when they get activated. And what they do is they serve to shut off the immune response. So right when you start an immune response, you already have a mechanism in place to turn it off to prevent collateral damage, which could be incredibly devastating. And so this happens normally for our exposures to pathogens, but it also happens in tumors. And since the natural history of tumors is much, much longer than it is for a bacterial infection, these mechanisms become incredibly important. And it became clear that if you targeted these mechanisms of safety, really, that you can augment an immune response. And so in this diagram here, you can see a tumor cell expressing the ligand for PD-1, which is PD-L1 or PD-L2, and that when you block the interaction of these two molecules, you prevent this sort of protective suppression of the T cells, and you can have continued activation and proliferation of these T cells, which augments anti-tumor immune responses. These are the antibodies that have been used clinically that we'll talk about moving forward against this pathway. Pembrolizumab is an antibody against PD-1, atezolizumab is an antibody against PD-L1, and durvalumab is an antibody against PD-1. And it also follows suit that if you have immune cells within a tumor, maybe you're more likely to respond to immunotherapy. You have the mechanism in place, you just need to activate it. And also that if you had the expression of PD-L1, which is the target here, then you would potentially have better outcome by targeting the PD-1, PD-L1 pathway. And this, for the most part, but not completely, ends up being true. These are data from a study of neoadjuvant pembrolizumab with chemotherapy in triple-negative breast cancer. And we look at the frequency of complete pathologic response, whether or not there is PD-L1 expression in the tumor microenvironment, or there is the presence of stromal TILs. And what you can see is that PD-L1 expression or TILs does concentrate a group of patients that are more likely to have a complete pathologic response, but it's not absolute. There are plenty of patients who don't have PD-L1 expression who get a complete pathologic response, and the same for TILs. And there are also patients who don't have a complete response, who do have high PD-L1 expression and have TILs present in a tumor. So these two are biomarkers, but they are by no means great biomarkers. This was also seen in the Keynote 522, which was a larger phase 3 study. And in this setting, we have the benefit of having a placebo arm. And what you find is, like we saw before, is that the presence of an immune response, here indicated by PD-L1 expression, is also indicative of response to chemotherapy. All these patients got chemotherapy, and what you could see is in the placebo arm, if you were PD-L1 positive, you were more likely to have a complete pathologic response than if you were PD-L1 negative, even without immunotherapy. This was augmented with the presence of immunotherapy, but nonetheless, PD-L1 ends up being a biomarker, not just for immunotherapy, but also just response to chemotherapy, which again is a problem when you're looking for an accurate biomarker to figure out who needs immunotherapy versus who doesn't. But very clearly in this trial, there was an increase in complete pathologic response rate with the presence of immunotherapy, and we'll hear more about that for a second. However, people still had an equal degree of change to complete pathologic response or increasing complete pathologic response with immunotherapy, regardless if they were PD-L1 positive or negative. And this is another phase 2 neoadjuvant study, again with a placebo arm. And again, you see the same effect, that TILs, as well as PD-L1 expression, are indicative of outcome in general and may not necessarily be entirely specific to immunotherapy. So we clearly need better biomarkers. And I think this is going to come from a better understanding of the tumor microenvironment. These agents lead to changes in T cells, but these changes trickle down to a number of different components within the tumor microenvironment, including macrophages and stromal cells and other immune cell subsets like myeloid cells. And we need to be better able to understand how this entire unit functions as together in order to figure out how to best target it. And as we develop new drugs to target the various components of the immune microenvironment, we need to be able to better figure out who will benefit from what on an individual patient level. Now, this is a daunting task because of how complex this is. It's not as easy as figuring out if there's a HER2 amplification, for instance. But as the technology for things like single cell sequencing and high dimensional multi immunofluorescence and other mechanisms of looking at spatial immune heterogeneity become more commonplace, I hope that we can better stratify patients for immunotherapy. So with this sort of preclinical discussion, I'm going to turn it over to Dr. MacArthur, who's going to run us through the clinical data in much more detail, as well as some strategies to increase the immunogenicity of triple-negative breast cancers.
Thank you, George, for that kind introduction, and thank you for including me in this terrific program. George, you just elegantly explained why chemotherapy is likely a good partner that synergizes with immune therapy. And so I'd like to start with a clinical trial that actually led to the first US FDA approval for immune therapy for the treatment of breast cancer. And that's the Impassion 130 study. This is a study where patients with previously untreated metastatic or inoperable triple-negative breast cancer were randomized in a one-to-one fashion to receive nab-paclitaxel as the chemotherapy backbone with either atezolizumab, the PD-L1 directed antibody that George just described, versus placebo. And the study was first designed to look at progression-free survival only as a primary endpoint and was later expanded during the course of the study to include a co-primary endpoint of overall survival, which is critically important in the path to FDA approval, and we'll touch on that in a moment. But first, I wanted to start by looking at a few of the baseline characteristics. I think it's worth noting that approximately 40% of patients had de novo metastatic disease, and that's a proportion that's potentially higher than what we see in routine clinical practice. It's also worth noting that approximately 40% of patients in this study had tumors that were PD-L1 positive by a specific assay, the Ventana SP142 assay. And this will be important later on as well. So here's the first primary endpoint, progression-free survival analysis. There's an improvement in the intention to treat population, 5.5 versus 7.2 months. And then looking at the PD-L1 positive subset, there's an improvement in progression-free survival from 5 months to 7.5 months. Then looking at the co-primary endpoint of overall survival, there was not a significant improvement in overall survival in the intention to treat population. And so to look at the PD-L1 positive subset for overall survival, the intention to treat population analysis had to be statistically significant, and it was not in this case. So instead, they did an exploratory analysis looking at overall survival in PD-L1 positive, so again, not statistically supported, but demonstrated in the first analysis a 9.5-month improvement in overall survival from 15.5 to 25 months, which is really remarkable because patients with metastatic triple-negative breast cancer typically have a life expectancy in the order of 12 to 18 months historically. So to see a 9.5-month improvement in overall survival is really unprecedented and generated a lot of excitement. This overall survival analysis was subsequently updated with a maintained 7-month improvement in overall survival from 18 to 25 months in the PD-L1 positive subset. So this data led to the FDA approval on March 8th, 2019 of atezolizumab in combination with paclitaxel protein-bound for adult patients with unresectable, locally advanced, or metastatic triple-negative breast cancer whose tumors express PD-L1 on immune cells of any intensity covering at least 1% of the tumor area as determined by an FDA-approved test. So again, the Ventana SP142 assay was the one that was applied in the Impassion 130 study that led to these results, again, with approximately 40% of patients in that study with tumors that were deemed PD-L1 positive. More recently, we've seen the results of the Keynote 355 study. This is a very similar study in some regards, although there are some unique differences from the Impassion 130 study that I just showed you. So similar population, previously untreated, locally advanced, or inoperable metastatic triple-negative breast cancer. In the Impassion 130 study that I just showed you, there had to be a treatment-free interval of 12 months between the curative intent treatment and the diagnosis of metastatic disease. In this case, it was only 6 months, so potentially a higher risk population. The randomization in this case was to chemotherapy with either pembrolizumab or placebo. And in this case, there was physician choice of chemotherapy, either nab-paclitaxel, paclitaxel, or gemcitabine with carboplatin. The primary endpoints, again, are similar: progression-free survival in patients with PD-L1 positive tumors, as well as the intention to treat population, and overall survival analyses for those two populations as well, the PD-L1 positive and the intention to treat. In looking at the intention to treat characters, the baseline characteristics rather for the intention to treat population, using a different assay, the 22C3 assay, that gives a combined positive score, so different than the Ventana 142 assay. Here, PD-L1 positivity, as defined as a combined positive score greater than or equal to 1, was present in 75% of the population, and approximately 40% of the population had a combined positive score greater than or equal to 10. So again, enriching for cells that are, or populations that are more innately immunogenic. In this study, fewer patients, only approximately 30% of patients had de novo metastatic disease, whereas in the Impassion, again, it was approximately 40%. So slight difference in the baseline characteristics. And here's the progression-free survival for the intention to treat population, a very almost identical hazard ratio to what was seen in Impassion of 0.82, with an improvement in progression-free survival from 5.6 to 7.5 months. And when you parse it down to the PD-L1 positive subsets as defined by the combined positive score of 1 versus 10, you can see that that progression-free survival is magnified for the greater than or equal to 10, 5.6 months versus 9.7 months. We haven't yet seen the overall survival data from this study, so that data is still highly anticipated. We also recently saw the results of the Keynote 119 study. This is a study of patients who had had 1 to 2 prior lines of therapy for metastatic triple-negative breast cancer. They were randomized 1-to-1 to receive either pembrolizumab or investigator's choice of chemotherapy. So investigators could choose from capecitabine, eribulin, gemcitabine, or vinorelbine, all chemotherapeutics that we use frequently in the metastatic setting. So again, comparing those physician choice chemotherapy to immune therapy as monotherapy. And in exploring the overall survival, there was no improvement in overall survival when comparing either strategies when looking at the intention to treat population or the PD-L1 positive subsets as defined by combined positive scores of greater than or equal to 1 versus greater than or equal to 10. Although you might look at this data and say that the immune monotherapy performed equivalently as chemotherapy, and a discussion could be had with patients regarding side effects when those choices are being considered. In an exploratory analysis, so this was not part of the primary endpoint, looking at an enriched population for immunogenicity, so the combined positive score greater than or equal to 20, there was an improvement in overall survival from 12.5 to 14.9 months. Again, this is an exploratory analysis with hypothesis generating data. Whenever we see strategies that work well in the metastatic setting, we often move those strategies into the curative intent setting to see if we can improve cure rates. And we have a growing body of data looking at immune therapy with curative intent. We first saw data from the I-SPY 2 trial. So this is a trial with an adaptive design that folds in multiple medications with a view to identifying estimated pathologic complete response rate. So it's not designed to compare arms head to head, but instead it's designed to identify strategies that are most likely to be successful in a randomized phase 3 setting. So in one part of the I-SPY 2 trial, there was an arm where paclitaxel was co-administered with pembrolizumab prior to doxorubicin with cyclophosphamide in the neoadjuvant setting. And when compared with the paclitaxel without immune therapy arm, improved the estimated pathologic complete response rate by 3-fold. So the pathologic complete response in the paclitaxel alone arm was 20% versus 60% when pembrolizumab was combined with paclitaxel. So that was really the first signal that we had that immune therapy might be incredibly important in the curative intent setting. We've since seen data from the Keynote 522 study. This is a large randomized study randomizing patients to receive neoadjuvant chemotherapy with either placebo or pembrolizumab. In this case, the chemotherapy was comprised of paclitaxel with carboplatin prior to an anthracycline with cyclophosphamide. There were various stratifications by tumor size, nodal involvement, and how the carboplatin was administered. So this is all in the curative intent setting for triple-negative breast cancer, essentially in patients who had stage 2 or 3 disease. And as George already mentioned, the Keynote 522 met the primary endpoint of improvement in pathologic complete response with the addition of pembrolizumab. So there was a 14% improvement in pathologic complete response with the addition of pembrolizumab. And in contrast to what we saw in the metastatic setting, PD-L1 status did not predict for response to pembrolizumab. In fact, the magnitude of the benefit in the PD-L1 negative subset was actually larger than that seen in the PD-L1 positive subset, specifically 18% in the PD-L1 negative versus 14% in the PD-L1 positive. So in this setting, and there may be a variety of reasons for this, newly diagnosed disease, untreated disease, the microenvironment might be different, but in this case, and in contrast to what we have seen now in 2 metastatic settings, PD-L1 status does not confer the same predictive impact as it does in the metastatic setting. And what's particularly exciting is the hint of improved cure rate. So this was data that was presented at a median 15-month follow-up. And so this is very unstable data and further follow-up is required. But the point estimate at 18 months is an improvement in event-free survival of 6%. So that improvement in pathologic complete response of 14% seems to be translating into early improvements in cure rates, which makes these strategies incredibly exciting. We also recently saw a press release from this study. This is the Impassion 031 study. This is a study which looked at a chemotherapy backbone of nab-paclitaxel followed by doxorubicin with cyclophosphamide with either placebo or atezolizumab. So in this case, the PD-L1 directed antibody versus placebo. And in this case, carboplatin was not part of the chemotherapy backbone. And this regimen was administered prior to surgery. And on Wednesday, June 17th, we saw this press release that the phase 3 Impassion 031 study met its primary endpoint by demonstrating a statistically significant and clinically meaningful improvement in pathologic complete response for treatment of patients with triple-negative breast cancer, regardless of PD-L1 expression. So similar to the Keynote 522 experience where PD-L1 expression did not predict for response to immune therapy in the curative intent setting. And so we've only seen the press release so far, but the details of that study are highly anticipated. There are a few other studies that have been reported that are worth noting. The NeoTrip study of neoadjuvant carboplatin and nab-paclitaxel with or without atezolizumab in the curative intent setting with anthracycline-based chemotherapy in the adjuvant setting. And in contrast to the two large randomized phase 3 studies that I just showed you, this study did not meet an improvement in pathologic complete response overall, or in the PD-L1 positive or PD-L1 negative subsets. Although it's worth noting that this study was not powered to demonstrate improvements in pathologic complete response. It's actually powered to look at event-free survival as the primary endpoint. So further follow-up from this study is needed to contextualize these findings. We've also seen the results of the GEPAR-NUEVO study. So this is a study looking at nab-paclitaxel followed by an anthracycline-based regimen with cyclophosphamide in the neoadjuvant setting with either placebo and durvalumab, so another immune therapy agent. And in a subset of patients participating in this study, they received a run-in with durvalumab before chemotherapy was initiated. And this speaks to the timing of how we apply these therapies and sequence. So the GEPAR-NUEVO study demonstrated a 9% improvement in pathologic complete response with durvalumab. However, this was not statistically significant. In an exploratory analysis looking at that subset of patients, however, that had that run-in with the durvalumab prior to initiation of chemotherapy, there was an almost 20% improvement in pathologic complete response, indicating that timing and sequencing of these agents may be critically important. Again, this is hypothesis generating, as it was not a pre-specified endpoint and was an exploratory endpoint, but it does beg the question, should we be introducing these immune therapies earlier on? It's worth noting that there are a number of large global efforts to explore immune therapy in the adjuvant setting. So I've showed you all the neoadjuvant data that's been reported to date. Here are the studies that are going on in the adjuvant setting that you may want to be aware of. First is the SWOG 1418 study, and Lajos Pustai from Yale is championing this effort. This is a study where women with residual triple-negative breast cancer after standard of care chemotherapy, so those who are at a very high risk of recurrence, are randomized to pembrolizumab with observation, and notably adjuvant capecitabine is permitted in this study, and this study is near completion of enrollment. There's also the ongoing Impassion 030 study, of which I'm co-PI. This is a study looking at paclitaxel for 12 weeks, followed by doxorubicin with cyclophosphamide. It's an open label study where half the patients also receive atezolizumab, asking the question of whether immune therapy can augment chemotherapy for treating micrometastatic disease. And that study is enrolling globally. And we talked a lot about chemotherapy, but is chemotherapy the only rational partner for immune therapy? And I would argue that it's not. So we know that radiation is immunogenic. Radiation brings immune cells into the tumor. So that could be critically important for augmenting immune responses. But it also physically disrupts the tumor, breaking it down into pieces that might be more easily digested by the immune system. So improving antigen presentation to immune cells and then boosting the immune response to more robustly process that information. There's a lot of preclinical data that has been generated in many labs, including Sandra DeMaria and Silvia Fermenti. This is one example showing the synergy between radiation and immune therapy in the form of CTLA-4 in this case. And there's a growing body of clinical data now demonstrating that these combination strategies may be very effective. So this is a study that I undertook together with my colleagues at Sloan Kettering and Alice Ho specifically, where we enrolled women with metastatic triple-negative breast cancer for whom palliative radiation was planned, and we co-administered pembrolizumab to see if there were any responses to be conferred outside of the radiation field. So our primary endpoint was looking at response of tumor outside of the radiation field. And it's worth noting that responses to immune therapy alone in heavily pretreated triple-negative breast cancer are in the order of approximately 5%. So immune therapy in pretreated populations is not particularly effective, but we hypothesized that if we co-administered with radiation, it would be. And here's an example of a patient who had a breast primary still intact, as you can see at the end of the red arrow, and this is what was irradiated. And afterward, you can see that all the other black areas, the other areas of metastases, responded. So she had a so-called abscopal effect outside of the radiation field. And we actually had 3 patients who had similar 100% responses outside of the radiation field, one that was ongoing beyond 2 years and didn't require any systemic therapy. So again, at diagnosis, metastatic triple negative breast cancer is typically associated with a life expectancy of 12 to 18 months. So to have a patient who had received prior lines of therapy go on after 2 years and not require any further systemic therapy is really exceptional, and made us even more excited about these strategies. So we since undertook a study of preoperative immune therapy with radiation prior to standard of care chemotherapy in patients with triple negative breast cancer, and have observed a pathologic complete response rate in our initial cohort of approximately 71%. And that further fueled enthusiasm, and a subsequent randomized phase 2 study is planned looking at that same strategy before standard of care chemotherapy versus not. Another strategy that causes immune infiltration in tumors and physically disrupts tumors to better present antigens to the immune system is cryoablation or tumor freezing. This is work that was done by Becky Waits in Jim Allison's lab when he was at Sloan Kettering, and Dr. Allison won the Nobel Prize a couple of years ago for his seminal work in identifying checkpoint blockade mechanisms and the successful subsequent drug development targeting those mechanisms. And this is work that they did where they froze a tumor in the flank of the mouse, boosted the immune system, and then tried to inject a tumor in the contralateral flank. And they found that the combination of cryoablation with immune therapy actually protected from tumor rechallenge. So the immune response to the initial flank tumor was so robust that they could not implant that same information. And the promise of that is that if you can successfully train the immune cells to recognize cancer, if that same immune system were faced with a recurrence, for example, it would automatically eradicate that recurrence without the affected individual even knowing. So that's the incredible promise of immune therapy. And so when we became aware of Becky Waits's work and Jim Allison's work with the cryoablation, we undertook a study where we took women who were undergoing mastectomy, and we worked backwards from their mastectomy date to administer cryoablation and checkpoint blockade. Here's one of the cases, and you can see the tumor there in white, and in the center, the black dot is the tip of the cryoablation probe, which is about the size of a biopsy needle. We then created an ice ball at the tip of the cryoablation probe, and then after a couple freeze-thaw cycles, you can see the fragments of tumor within the tumor bed. And we were able to demonstrate that not only were we able to generate a robust immune response with the combination of tumor freezing and immune therapy in this setting within the tumor, but we were also able to create a robust systemic immune response, indicating that we had successfully trained immune cells to actually recognize and remember cancer-specific information. So Elizabeth Coleman at Sloan Kettering subsequently championed a study of dual checkpoint blockades, so incorporation of 2 immune therapy molecules with cryoablation, and that publication is pending. And we have since undertaken a multi-center randomized phase 2 study where we're taking women who are at high risk of recurrence, so those women with residual triple negative breast cancer after standard of care neoadjuvant chemotherapy, and randomizing them to receive standard of care or the strategy that I just showed you, which is immune therapy with cryoablation. And I'll stop there.
Thank you, Heather. That was fantastic. Really an incredible amount of progress in a relatively short time. And some of the exciting work that you're heading up really highlights the sort of ingenuity that we're using to increase the immunogenicity and potentially the benefit of immunotherapy to more patients. So now for the practical part, and I think that one of the discussion points that often surgeons like to hear about is how we incorporate immunotherapy into our surgical practice. And I think, of course, that the most important thing to highlight right off the bat is that while we do have an approval in the metastatic setting, there is no approval for immunotherapy in the neoadjuvant or adjuvant setting. So these are all sort of discussions, theoretical discussions, really, if there is an approval. And that at this point in time, immunotherapy in the neoadjuvant or adjuvant therapy should be for a study design or for a clinical trial. So in light of that, the idea that we should select patients for immunotherapy is an important one. And it can come from two factors, one being a biomarker and the other potentially being a clinical biomarker. And so the clinical data, one of the interesting variables that came out of the Keynote study in the neoadjuvant setting is that maybe patients that have nodal disease have a greater response to neoadjuvant immunotherapy, complete pathologic response, than those that don't. And so that potentially could be a selection criteria. Are there other factors, Heather, that you might think are important?
Well, for the two large randomized phase 3 studies that I showed you, eligibility was really limited to patients with stage 2 or stage 3 disease. So again, benefit seen in higher risk populations. But we do need longer follow-up to determine what the long-term impact is, both in terms of improvement in event-free survival with more stable data, but also predictors of toxicity, biomarkers of toxicity, because there is potential for long-term sequelae due to immune therapy. And in a curative intent population, that could be clinically very impactful. So we need to better understand how we can enrich for patients who might benefit, but how we can also protect those who might be at risk for long-term toxicity.
So this brings up an incredibly important point that we should discuss, which is the toxicity associated with immunotherapy. And like you mentioned, this becomes particularly relevant in the curative setting, particularly with triple-negative breast cancer, with our patients in general being younger. So a brief discussion about the immune-related adverse events, I think, is in order. And the main differences between the well-described and side effects of chemotherapy versus immunotherapy is that the profile is somewhat variable still. We don't have a great grasp on it. The organ systems that are affected can be highly variable. It's not what we've come to expect with chemotherapy and marrow suppression, for instance. And the time course could be even more variable. And so all these factors, these differences, make it relatively unpredictable. And I think that it highlights the importance of clinical expertise, particularly when you have a multidisciplinary team. The person that has the most experience with these agents should take the lead and kind of inform the rest of the group as what to look out for and what to screen and how to safely get our patients through surgery. Now, the good news is that in the Keynote study, at least, there was no clear delay to surgery. Both arms made it to surgery equally, and so that wasn't an issue. We got patients safely to surgery and safely through surgery. But nonetheless, like we said, the natural history of these adverse events could be long. Now, I don't necessarily have been given immunotherapy, but maybe you could just walk us through a little bit of what we would expect to see in this patient population, Heather.
Absolutely. So I think, especially for this audience, just to build on what you just said, George, it's important to understand the timing of immune therapy and that there can be delayed toxicity even up to a year after your last exposure. So we typically only think about toxicity when people are actually on active treatment, but that is an important distinguishing feature that even a year after completing immune therapy, that toxicity can occur. And immune therapies can affect really any organ system, the endocrine system most commonly, but also respiratory with pneumonitis, hepatitis, nephritis, musculoskeletal, neurologic, and so on. So vigilance is really critical, and any any new event should be considered as a potential immune-related side effect. Fortunately, the most common side effects from chemotherapy with immune therapy in both the metastatic and also the curative intent setting in 522, for example, comes from actually the chemotherapy backbone. So the chemotherapy is what accounts for most of the toxicity that's observed. The incidence of common side effects were relatively low with single agent immune checkpoint inhibitors in the Keynote 119 study. The immune-related adverse events to be aware of are, as I said earlier, most commonly thyroid issues. So approximately 15% rates of hypothyroidism, and this has been very consistently observed across clinical trials, with hyperthyroidism being less common. Rash, pneumonitis, adrenal insufficiency, hypophysitis, hepatitis, and colitis are fortunately much less common. As you pointed out, George, the timing is very variable. This is a general indication of expected time course, but again, there can certainly be variations on this. Rash can occur very early, as can diarrhea, and endocrine liver and lung issues are typically more delayed 4 or more months on treatment. But again, vigilance at all time points is critically important. How do we manage the immune-related adverse events? Well, steroids are the most commonly used drug to manage immune-related adverse events. Thyroid-specific medications are used to manage the hypo and hyperthyroidism. If caught early, then oral steroids typically suffice. Intravenous steroids are saved for more severe immune-related adverse events. So again, vigilance is critically important because the earlier these complications are identified, the easier it is to reverse them. And it really takes a multidisciplinary group to manage these immune-related adverse events, again, because any organ system can be affected. The oncologist is typically the driving force behind the consultations, but really relies heavily on our colleagues in other specialties to help manage these very diverse side effects.
So this brings up the question that often surgeons ask is, what do we need to know? And I think that the critically important thing to know is that these can happen, and to look out for common signs of endocrinopathies, because the endocrinopathies more often than not could be potentially devastating in an intraoperative setting, particularly adrenal insufficiency. So it's important for surgeons to understand that these toxicities can occur, how they may present clinically, and also just to look at common things that we do, like we run labs and look at the BMP for changes, and even just ask questions to patients, targeted questions that would point to various endocrinopathies. And so I think that's critically important for surgeons to know. And like you mentioned, this multidisciplinary management ends up being key. Let's look at some other questions that are being submitted to us by the audience. Are perioperative complications higher in patients receiving immunotherapy? So this does not seem to be true, at least complications related to surgery. Like I mentioned in the Keynote 522 trial, the patients made it to surgery, made it through surgery equally between the arms. And also the experience of melanoma, I think is pretty clear, where there's a much greater depth of experience, even operating on patients who have been immunotherapy for a while, they can safely get them through more larger and complex surgeries.
I would just add, George, that because I get a lot of questions from surgeons about the radiation, cryoablation, immune therapy combinations and the effects on wound healing. And to date, we have not, with either cryoablation and immune therapy or radiation with immune therapy in the curative intent setting, have not observed any wound healing complications or delays in surgery. And with the radiation, there was upfront concern that it could alter the aesthetics of the surgeries, the surgical outcomes. And so actually in our radiation immune therapy study, we actually took serial photographs so that we could demonstrate that the aesthetic outcome was not undermined with the preoperative radiation. So I just want to reassure our surgical colleagues that these strategies are being applied very safely and don't seem to be undermining both the acute and chronic outcomes of curative intent surgery.
I think that's incredibly important because we definitely need to get patients on these incredibly important clinical trials to try to maximize immunotherapy for our patients. So it's reassuring to hear that so far it's been going safely. Why do patients with PD-L1 positive tumors seem to have similar benefit to patients with PD-L1 negative tumors in the neoadjuvant setting, but not in the metastatic setting? Well, that's a very interesting question, and unfortunately not one that we have an answer to. But one of the things that we've noticed is that there is a change in the immune response to cancer based on sort of the stage of disease. And so if you look at serial biopsies in various metastatic lesions versus the primary, or patients who had a primary and then developed a metastatic lesion, you will see that the immune response changes and in general gets more dampened over time. It also gets more dampened with lines of therapy. And so I think that the natural history of the immune response changes with the clinical course and with our interventions. And I think that may feed into it to some degree. In Keynote 522, patients receive neoadjuvant therapy followed by adjuvant therapy. But what do you do with patients who have residual disease? Well, I think we don't really do anything clinically now because we don't have an approval. But what would we do in the future if we did have an approval, for instance? I imagine the issue here is about capecitabine. Heather, do you have any comment regarding that?
Yes, I think your comment about not having an FDA approval at the moment is critically important. We will have data from the SWOG 1418 study. That's again a study for patients with residual disease after neoadjuvant chemotherapy, so not after neoadjuvant chemotherapy with immune therapy. But it will tell us what the role is for continuing immune therapy for those who have residual disease versus not. And I think in the real world, people will probably co-administer capecitabine in that setting after they start applying the Keynote 522 regimen once we do have an FDA approval, even though that was not permitted on the 522 study. But there is data from the early metastatic setting study that Dave Page from Portland, Oregon conducted looking at the combination of capecitabine with pembrolizumab versus paclitaxel with pembrolizumab for metastatic disease, and saw very robust responses with the capecitabine pembrolizumab combination. So I think it would be reasonable to extrapolate from that setting. But you're absolutely right. We don't have any ongoing studies that will directly ask and answer that specific question.
So hopefully more to come there. Great. So with that, I'd like to end. And Heather, I'd like to thank you very much. This has been incredible. This is really an exciting sort of intersection of the data from the metastatic setting to the earlier stage setting. And it clearly highlights how we all have to work together to sort of safely usher in this new era of immunotherapy for our patients. And again, thank you. Thanks again, Heather. It's been great. And everybody have a good evening.
Thank you.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/GKC860.